Happy Tuesday, everybody. Welcome to Department of Medicine Grand Rounds. We are so excited to bring to you today BEAST Mode. For those unfamiliar, that stands for Bite-Sized Teaching Mode Conference. And every year we've been delighted to have as their swan song our chief residents presenting for their final hoorah before they leave us. For those unfamiliar with Beast Mode, here's how it works. Instead of a 1-hour lecture over the course of the conference or grand rounds, instead what happens is you get a series of mini or bite-sized lectures. The unique thing about Beast Mode is that individuals pick a very short list of objectives and really tackle a small list of objectives instead of something much bigger. All the fat is trimmed and the focus is really on delivering an idea. It's kind of where the TED Talk meets medical education. Generally what we do, and this will be no different, is that our chief residents will each speak in succession, one after the other. There will not be questions after each speaker. What happens is that at the very end, we have a little time, if possible, but it's because we have 6 speakers this time, we may not, but we're able to take a few questions at the end. The exciting thing about today, normally for Beast Mode, we have a theme, but we allowed our chief residents to talk about something that they wish to talk about. So some of the topics are medical topics, teaching you about medical knowledge, and some are about ideas, and even some are about reflection in medicine, all of which I think will impact us all in some important way, and that's really ultimately our goal in what we do. I'd like to introduce our 6 fantastic speakers, also known as the Six-Pack, by nobody but me. In order of presentation, Catherine Bartnik, also known as Kat, is our first speaker today, and Kat went to undergrad at Kalamazoo College, K College for short, did a master's at University of Michigan, and went to medical school at Michigan State before coming to us for medicine. Our next speaker, Andrew McCue, he comes to us from the great state of West Virginia, and because he loved West Virginia so much, he went there to West Virginia University for his undergraduate and medical school studies, and we took him away to come to Emory, where he stayed as chief and will be starting as a cardiology fellow. Our next speaker is Dr. Tyler Peck. Tyler Peck is one of our chief residents over at Grady Hospital. Tyler went to undergrad at WashU and then came to Emory University for medical school and joined us for residency after that. Our next speaker at the Atlanta VA is Mayur Mody. Mayur Mody is a proud alum of University of Florida, wears his pen proudly. Of Hopkins for undergrad, but went to University of Florida for medical school. Is that correct? Got it. All right. Our next speaker, Dr. Spencer Maddox. Dr. Spencer Maddox went to Auburn University. I will not mess that up. Auburn University for his undergraduate studies, and he was in the first graduating class at MCG Athens campus, and then came to us for residency. He's the chief resident at Emory University Hospital. And our final speaker is Dr. Alejandra Bustillo, Ale for short, as we know and love her as. She went to the University of Michigan and went to medical school at University of South Florida. So what you can expect is to see each of these speakers speak one after the other. And I hope you enjoy Beast Mode today and really enjoy this celebration of medical education. And we just are so grateful to each one of our chief residents for the fine job you've done teaching this year. So thank you for that. Our first speaker.
All right. Thank you for that introduction, Dr. Manning. I'm going to talk today about the code of silence, the suicide epidemic among us. Many of us were shocked last week to learn about the untimely deaths of Kate Spade and Anthony Bourdain at a very early age. And this came right at the announcement by the CDC that the suicide rates in the United States have risen up to 30% across the country since 1999. Unfortunately, our medical community has not been shielded by the rising suicide rates. These are the faces, the medical students, some residents, attending physicians that have lost their life to suicide since 2013 that have been highlighted in the media. Why does this matter, and why has this become a public health crisis? How do we identify those at greatest risk for suicide? And how do we curb this epidemic? It has been estimated that 300 to 400 physicians die by suicide each year. That equates to one individual, one physician dying every single day in the US. How does this translate to our patient care? One primary care physician annually cares for 2,300 patients in their patient panel. If we extrapolate the 400 physicians that die on an annual basis, this equates to roughly 1 million patients that lose their primary care physician. When we couple that with the looming physician shortage, who is going to care for our patients in the United States if we continue to allow this epidemic to occur? What is even more surprising is that the suicide rates in our occupation is more than double that of the general population, and it's even greater than the military. What's surprising too is that women are at a greater risk than men. So why is this occurring? It's not a shock that medicine is a very stressful environment. Burnout is ubiquitous across the different stages of medical training. There are certain factors that are probably more prominent in the medical school training environment. They're concerned about their board exams, applying for residency, and this pressure to be perfect. When they advance to residency and start to practice medicine independently, maybe creating a medical error or thinking about the financial burden of their medical debt or sleep deprivation from long hours. Even advancing further to an attending status, having even greater independence, physicians may be named in lawsuits or have difficulty navigating the insurance networks. But one thing we need to remember is that physicians come to the medical community with a number of other risk factors, such as major depression, relationship problems, substance abuse, domestic violence, and possible prior suicide attempt. The next slide is taken from the American Medical Association Steps Forward online module, Preventing Physician Distress and Suicide. And while I'm not going to spend time going over each individual warning sign that's listed on this graphic, what I do want to highlight is that we need to educate ourselves and our community about warning signs and how to identify those at greatest risk. I want to take a pause here and talk about suicide as a little bit different of a concept, rather than the completion of an impulsive act, but rather as a continuum. Typically, it starts with an intrusive thought. Unfortunately, we physicians have all the tools in our armamentarium to potentially complete suicide, because we actually have the knowledge from an anatomical and physiological standpoint in how to do that. We also have access to medications and understand lethal doses of those medications. We also are in an environment where there is stigma around mental health, and it may prevent individuals from coming forward and talking about those intrusive thoughts. Potential reasons for why physicians have difficulty coming forward are outdated views of consequences. Maybe they're concerned that their hospital privileges will be revoked. But the last point is actually the one I want to highlight the most, this fearlessness of death. We are around death maybe on a daily basis or on a very frequent basis, and we learn from even our medical school training to normalize it, to cope with this process, that we are constantly surrounded by death. And I fear that that is what can propel an individual to go from an intrusive thought to finally completing an act. So how do we intervene? There are a number of down-to-earth solutions. So the first and foremost is that we need to talk openly about it. We need to destigmatize suicide and mental health. We also need to educate the medical community to identify risk factors and warning signs. One of the most important is that we also have to allow for access to mental health and treatment, and to allow physicians to come forward. And we also need to follow up and allow physicians to have a safe, supportive environment to discuss their mental health concerns, as well as to create policies that separate mental health from the academic training environment. One institution, the University of California, San Diego, created the HERE program, which utilized the interactive screening program, which is an online self-assessment tool that identifies at-risk individuals and links them to care. They created a safety net within their own community, and by doing so, they've linked greater than 180 physicians and trainees to care. Our own institution has a similar screening online assessment tool, and it's found on the Faculty Staff Assistance Program website. And I encourage you to go to this website and familiarize yourself with it. So I'll leave you with this final thought. Physician suicide has reached public health crisis proportions. We need to stand together to create and break the code of silence so that we have the tools to not only help our own individual colleagues, but also for patient care. There are a number of resources available, including the National Suicide Prevention Hotline, and I encourage you to look online. This slide will be available for resources after the discussion. Thank you.
Good afternoon, everybody. Today I'm going to talk to you about VTAC versus SVT with aberrancy. I think this is a very important topic because at some point in your medical career, whether you be an internist or a subspecialist, you're most likely going to be faced with the sudden onset wide complex tachycardia. And getting to the diagnosis is not always a straightforward approach. And I want to give you a few methods so that you can confidently come to a diagnosis and seek treatment in a very timely manner. So the learning objectives for this talk are to discuss how to approach a case of a wide complex tachycardia, discuss the Brugada criteria for VTAC, and highlight some associated clinical factors that can help you discern between VTAC and SVT with aberrancy. So our case, say you were a cross-cover resident here at Emory and you get a page from a nurse about tachycardia. She reads you the vitals, heart rate 200, blood pressure of 100/60, respiratory rate's 22, SATs are 100%, and afebrile. You quickly chart check the patient to find out this is a 38-year-old gentleman with a history of hypertension that was admitted for a syncope evaluation. And then you go to the bedside. At the bedside, the patient's awake and alert, complains of some lightheadedness, but really no chest pain, no shortness of breath. You quickly look at the telemetry strip, which shows you as we see here. So you then get a 12-lead EKG. So just to quickly run you through the EKG, what you see here is a rate of around 170. The rhythm, you see a wide complex tachycardia. For all sake and purposes for now, that's really all we can say about it. The axis, you're most likely here an inferior axis. You're isoelectric in 1, upright in AVF. Your most polarity is probably somewhere between AVF and lead 2, so we'll say this is around positive 90. And you see what could be a left bundle pattern looking at V1 and V2, looking at the negative polarity of the QRS complex. And for now, that really is all you can say about it. So let's apply some criteria to kind of help differentiate what this could be. Before, let's define the term aberrancy for those of you that might not be familiar with it. So aberrancy is aberrant conduction. So essentially, an electrical impulse takes an abnormal route through the conduction system. Normally, we go through the SA node to the AV node to the ventricles, and an aberrant conduction can be caused by a bundle branch block or an accessory pathway such as WPW. So when we refer to the term aberrancy, that's what we're discussing. So there are 4 simple rules, and these 4 simple rules really revolve around the axis of the electrical impulse. A normal axis starts at the SA node, upwards of the right shoulder, and travels down to the ventricles towards the left hip. Anytime you see a change from that, it's a concern that the electrical impulse might be starting elsewhere and not actually in the SA node in the atria. So first step is to look to see if there's extreme axis deviation present. Is there something going in the northwest axis towards the right shoulder? Do you see a large positive QRS and AVR? And if not, then move on to step 2. Step 2, is the QRS in V6 predominantly negative? V6 is placed right over the apex of the heart, and if the QRS is not moving in that direction and is moving away from it, if it's negative, that would suggest that the activity is starting in the ventricles, which would be consistent with VTAC. Step 3, does lead AVR have a large upright R wave? As we mentioned, that would suggest the axis is moving towards the right shoulder. And then step 4 really looks at the slope of the R wave going to the S wave. Is there a long slope suggesting a slow conduction, which would be something you might see in the myocardial tissue or in some of the bundles if there was something moving upwards and away through the ventricle path? So if those 4 simple rules, that will probably help you get to around 90% of your diagnoses. But if, in sense, looking at REKG, that might not be the case. If you have yes to any of those, it's VTAC. But if you need to go a step farther, we're going to look at the Brugada criteria that will hopefully help you get those other 5 to 10% of the diagnoses. So the Brugada criteria for VTAC, step 1 looks for concordance in the precordial leads. What this essentially means are V1 through V6, are they all positive or are they all negative? If so, this is very specific to VTAC. If not, it doesn't really help you with your diagnosis, so you need to move on to step 2. Step 2, is the R to S interval greater than 100 milliseconds in any of the precordial leads? Looking here, you see a long slope from your beginning of your R wave to the bottom of your S wave. This would suggest a slower conduction than what would be normal, and this is called Brugada's sign and is very specific to VTAC. Looking here, if you also see a notching of the R wave to S wave, this is called Josephson's sign and is also very specific to VTAC. Step 3, if you still haven't been able to meet your diagnosis, look for AV dissociation. Are the atria beating at a different rate to the ventricles? This can often be very difficult to see in a VTAC case because the heart rate could be upwards of 160, 180, 200 beats a minute. You can give adenosine to help slow the rate down to see if you can find those P waves, but oftentimes it's going to be very difficult to locate AV dissociation. But if you can find that you do have P waves that are not associated with each QRS complex and beat at a different rate, this would be very consistent with VTAC. And finally, I want you to look at V1 and V2. Discern whether you have a right bundle or a left bundle branch pattern. So if you look at V1 and you see a positive QRS, this is most likely a right bundle pattern. And if that's the case, in right bundle, you should have a rightward axis. But if you look and see you have an axis to the left of -30, that would be a considerable axis change and is consistent with VTAC. Also, you can look for the RSR pattern, and if you see a left rabbit ear taller than the right, this is also consistent with VTAC. If you look in V1 or V2 and you have a negative QRS, then this is a left bundle branch pattern. You would suspect a left axis in a normal heart. But if you see an axis to the right of +90, this would be suggestive of VTAC. If you see the slurring of the S wave that we discussed in the previous example, that would be also consistent with VTAC. Also, if you see a Q wave in V6, if you have a left bundle branch pattern, this is consistent with VTAC. So going back to our EKG, we said we saw a left bundle branch pattern, and we said our axis was around +90 degrees. So this EKG actually is representative of a right ventricular outflow tract ventricular tachycardia. So some things to consider. The Brugada criteria are helpful at around 85% in making your diagnosis. The initial studies that published this criteria have not been able to be reproduced as far as the sensitivities and the specificities of diagnosing VT. There are some newer criteria, the Varecki criteria, and the lead to R wave peak time. They're kind of out of the scope of this talk, but those are also things that can help aid in your diagnosis. And just keep in mind, these criteria are highly specific for VTAC, but if they are not present, that does not necessarily mean that this is truly SVT. The criteria are helpful to rule in VTAC, but not necessarily to rule out. There are some clinical correlates you can use to help confirm your diagnosis. Age greater than 35 actually has a positive predictive value of 85% of making the diagnosis of VTAC. Also, anyone in the structural or ischemic heart disease with a history of, you should just assume VTAC until proven otherwise. Things that might increase your likelihood of SVT with aberrancy. Any previous EKG showing a bundle branch block that has an unchanged morphology with an increased rate. Any previous EKG or anybody with a known history of WPW would also increase the likelihood of SVT with aberrancy. If in doubt, if your patient's unstable, shock them. You can ask questions later. You can consult your cardiologist. You can do EP studies, but treat the patient first, and then you can worry about getting to the diagnosis later. And shocking will treat the patient. Thank you.
Good afternoon. I'm Tyler Peck, one of the chief residents at Grady Hospital. I'm going to speak to you for a few minutes about interruptions in healthcare and distraction that's provided by many of our devices and things in the hospital. So I have no disclosures for this talk other than to say that I have personally been distracted in the healthcare setting by alarms, pagers, cell phone calls, CNN news alerts, and so on and so forth. So our objectives for today are to talk about the effect of distraction on healthcare workers and does it exist, to highlight the study of distraction within the field of human factor research, and to also review interventions that we can take to minimize distractions. So moving forward, I think inherently know that healthcare settings are full of distractions, but there are a few studies out there that really highlight this well. This is a study out of University of Utah where they watched nurses in the ICU setting. They observed over 1,000 nursing tasks being performed, and they found an interruption rate of those tasks at 29.4%. Another interesting thing was that after those tasks were interrupted, they found that the probability that the original task would be abandoned was 0.12%, or 0.12 rather. So a significant number of those tasks are potentially abandoned after the initial task is interrupted. This doesn't only happen in the ICU. This study out of a hospital in Toronto found that residents who were on the general medicine wards and carried a team smartphone had very high peak rates of distraction at really high traffic times of the day, for example, when the team is rounding. You'll see here that around 11 or noon, they were even reaching the rate of 4, 5, and 6 interruptions in a 30-minute period, which this paper labeled as kind of crisis mode, where really you're unable to maintain attention on a single task, but rather are very, very distracted. And this doesn't only apply to the devices and the cell phones that we carry to do our jobs, but it also applies to our personal cell phones. This study highlighted perfusionists in the OR during cardiopulmonary bypass and their personal cell phone use reaching 55%, and even accessing personal email and social media at those times. So do these distractions cause medical error? I will say that in this area, there's not been a ton of research correlating distractions directly to medical error, but we have a lot of other industries that highlight these types of risks. For example, the high-risk industry of airline travel. In 1972, there was an Eastern airline flight from JFK to Miami that the entire crew of the jet took on the problem whenever they were approaching the Miami airport. There was an indicator that the landing gear were not deployed. So the entire crew was trying to fix this problem. They were very focused. They went into a circling pattern at 2,000 feet. Unfortunately, as the pilots and the flight attendants were all working on this problem, they found that there was a problem with the autopilot function of the jet, and so the jet was continuously losing altitude and ultimately crashed into the Everglades. So this crew was very distracted by a task that put them away from their alternate task. So what can we do to address this problem? Unfortunately, there are people who think about these types of things in industries like healthcare. One example of this is the study of human factors, which is the application of physiological and psychological principles to the design of our systems. And I think this is relevant for us. So can we leverage what we know about human behavior and other characteristics to ensure that we're going to be able to provide safer and more reliable outcomes for our patients? So the subfield that really looks at this is cognitive ergonomics. We're all familiar with the ergonomics term in terms of using wrist pads to prevent carpal tunnel and so on and so forth. There's a similar application of this to cognitive studies where we really want to think about the risks that we're providing or we're creating for ourselves to cause failure in our cognition. Examples of this are disruption cost for interruptions. There's a cost to everything, and we'll look at that in just a second. Interruptions also cause cognitive overload for us. And the other thing in the healthcare setting that's very important is that interruptions can cause a loss of situational awareness or a loss of our ability to really just absorb information from our environment that may be very clinically relevant. So this was a study looking at undergrads from Florida State University and the attentional cost of receiving a cell phone notification. So they were doing rapid fire tasks. That's why you see that commission baseline error rate was pretty high, because these were very rapid identification of numbers on a computer screen. But you'll see that the group in the middle that received no notifications at all had a similar commission error rate between the two studies, versus for people who were either called or received a text message as they were receiving these prompts to take an action, they had a higher risk, a significantly higher risk of error in those tasks. And not only does this apply for us whenever we are actively receiving disruptions from our cell phones, it also applies to people who are high utilizers of media. For example, this study out of Stanford showed that people who were high media multitaskers, indicated by the solid line, HMM, had a lower performance at performing basic tasks as their number of distractions increased. So not only is the active cell phone use causing problems, but potentially high cell phone use at baseline for individuals is causing them to be rewired in some way such that they will be more distracted and unable to perform basic tasks. So what do I do with this information? So there are some best practices in the literature, and I think all of us can kind of take a look at how we personally can minimize distraction in the healthcare setting when it pertains to our personal cell phone. So the first step is always just to educate clinicians about this potential risk. We personally want to minimize technostress and distracting technology by eliminating unnecessary notifications when we're in the workplace, knowing that those notifications could potentially affect our performance and may increase our error rate. Another important overall arching theme is to reestablish technology use as a productivity tool for us, rather than a source of just endless distraction and a vacuum of being the first thing that we always turn to whenever we receive a notification or we're bored. There are specific reasons that this technology was developed, and we want to circle back to using it as a productivity tool. And then the other thing I encourage you to do is to make opportunities for yourself to break from technology and give yourself the opportunity to have rest in the form of a cognitive break, and also to reduce your dependence on the technology itself. There's my references. Thank you.
Hey everybody, my name is Mayur Mody. I'm the chief resident at the Atlanta VA, and I'm actually going to be starting hematology oncology fellowship here in a couple of weeks. So I wanted to talk to you all about something I think is very practical, and that's going to be acute leukemia recognition and management for the internist. So learning objective for today is to facilitate the prompt recognition and timely initial management of patients with acute leukemia. I think this is an important topic for us being on the front lines of healthcare, because these patients can walk into our clinic, they can walk into the emergency department, and they're presenting with an new acute leukemia that otherwise may be very difficult to pick up. I'm going to leave you with a couple of pearls using 4 steps that y'all can use to figure out if this patient has acute leukemia and what do you need to do about it, in addition to consulting me. So time is of the essence in these patients, and the American Cancer Society has estimated about 20,000 patients that diagnosed annually with one of the leukemias. And in this patient population, physician-related delays in diagnosis contribute greatly to poor outcomes and higher mortality. In fact, if a patient was to present to the emergency department versus in a primary care clinic, the earlier diagnosis and treatment would happen in the emergency department, which puts the burden on us to improve our best practices. And I think this is relevant for all subspecialties, because the same patient can easily present to a cardiologist for a pacemaker evaluation. They can easily present to the gastroenterologist for a screening colonoscopy, complaining of things like chest pain and coagulopathy. So it's something that we all need to take into consideration. So the 4 steps that we're going to cover: step 1, putting acute leukemia on your radar; step 2, proceeding with the appropriate workup; and step 3, recognizing and treating coexisting hematologic emergencies; and then step 4, getting the experts involved. So step 1, putting the acute leukemia on your radar. So like I said, the symptoms that these patients present with are oftentimes very nonspecific, very vague, and there could be several of them. For example, a patient could present with headache, chest pain, dyspnea, fever, and or coagulopathy. It's paramount to know when to include acute leukemia in the diagnosis, because otherwise it can go unnoticed. So in terms of the symptoms that acute leukemics present with, the pathophysiology behind it is one of 2 things: either bone marrow failure or direct infiltration of the proliferating leukemic blasts. So on the left, we have 2 bone marrows, one of a normal marrow and one of a patient with acute leukemia. You can see the patient with acute leukemia has the leukemic cells that are overcrowding and leading to bone marrow failure. If a patient has bone marrow failure, they can have anemia leading to fatigue. They can have thrombocytopenia leading to coagulopathies, and they can have dysfunctional immune cells or white blood cells, leading to neutropenic fever, neutropenic sepsis, infections. On the right, we have that second mechanism of pathophysiology behind the symptoms a patient may present with. Direct infiltration of proliferating leukemic blasts. That can happen both in the marrow, as we see on the bone marrow slide, and then also can happen in extramedullary sites, places like the CNS, the pleura, which are the two of the more common places where mortality is high if there is leukemic infiltration. So step 2, proceeding with your appropriate workup. The workup is fairly simple to putting leukemia on the radar. Getting the diagnosis is a little more complex, and that's when you need the hematologist. But getting screening for leukemia is fairly simple these days. All you really need is a CBC with automated and manual differential and a peripheral smear. Recent advances of technology have led to the CBC machines and that they use with the differentials to be able to pick up on other or atypical or blast cells, as you can see in the 2 CBC samples that I have posted there. The first one's a little more obvious, something bad's going on. The white count's 10 times normal, and there's about 89% of other cells or O cells. The bottom one is a little more subtle, and that's a patient that you don't want to miss in the clinic. A patient is, they're a little leukopenic, they're anemic, but they do have some atypical or other cells. This should be sent to a pathologist for peripheral smear review to get the screening, get acute leukemia on the differential while you're consulting the hematologist for the definitive diagnosis through a bone marrow biopsy. So recognizing and treating coexisting hematologic emergencies. Acute leukemias oftentimes present with several other very dangerous conditions I'm going to outline here. Each of these conditions is an hour or 2-hour talk on its own, so we're not going to go into much detail, but just having these on the radar and recognizing if this is someone that needs to go immediately to the emergency department is something that we should be able to do. So things that can happen is disseminated intravascular coagulation, or DIC, febrile neutropenia, tumor lysis syndrome, or leukostasis or symptomatic hyperleukocytosis. In an acute leukemic, a lot of the mortality is associated with one of these 4 conditions. And then finally, the last step is getting the experts involved. This, in theory, should occur really when you have the initial suspicion for the leukemia, because time is of the essence. And 2 considerations here. One, not only the hematology oncology needs to be consulted for definitive diagnosis and definitive treatment with chemotherapy, but you also need to take into consideration, if you're out in the community, whether or not this patient should be in your local center or needs to come to a specialized site. So we at Emory, that's not a problem for us. We have Winship Cancer Center right across the street. But in the community and the majority of our providers, this is a consideration. One of the things I did in residency is a project that looked at acute promyelocytic leukemia patients that were treated elsewhere versus that they were treated in conjunction, whether that's remotely or via hospital transfer here at Emory. And the outcomes were far greater when they came either remotely or to Emory directly for further treatment. So let's review our 4 steps. Step 1, putting acute leukemia on the radar. Think about those vague symptoms and think about the pathophysiology behind them, which is very simple: bone marrow failure or infiltration. Think about proceeding to the appropriate workup as step 2, your screening CBC, the automated differential, peripheral smear. Recognizing and treating coexisting hematologic emergencies. So the 4 things we briefly mentioned: DIC, febrile neutropenia, tumor lysis syndrome, and symptomatic hyperleukocytosis. And step 4, getting the experts involved, consulting hematology oncology, and then thinking about that hospital transfer, or thinking about a higher level of care or specialized care for those patients that need it. Thank you.
All right, so today I'm going to take some time just to talk about what I've learned in my first 6 weeks of being an attending here this year. It's not extensive experience, but I think I've got some pearls that will be helpful both to our graduating residents and as they move on and start their careers either in hospital medicine or after they finish their fellowship, and also to our more senior faculty to remind them of when they made this transition and what it was like and what things that you could potentially do to reinvest back into our junior faculty. Some of these pearls are going to be basically through metaphors that I'll go through. I want to be you when I grow up. You can't treat what you can't see. Remember June 2015 and the name on the door. Okay, so I want to be you when I grow up. This talks about the importance of mentorship. When I started my time as an attending this year, I realized that I really needed to establish mentors quickly. I wasn't able to do this on my own, and I needed help doing it. So this study here looked at surveyed academic physicians, and they asked them about mentorship kind of across all fields. And what they looked at was that oftentimes mentorship is there's not a lot of mentorship going on in medical institutions, but those that were mentored were significantly more likely to stay both in academic medicine and at their current facility and at their current institutions compared to those who were not mentored. So we know that mentorship is important both kind of from a health system standpoint and in keeping your faculty around, and also from an individual standpoint. So who should be the ones that mentor you? When I started here, it was a pretty obvious choice for me who my mentors were going to be, the two that we call the Dans, Dr. Dan Hunt and Dan Dressler. Both of them have been invaluable to me this year. Dr. Hunt and myself had the wonderful opportunity of co-attending my first 2 weeks of being an attending. So we took our patient list, split it down the middle. He was the attending on half the patients. I was attending on the other half. Every day we were able to watch rounds and watch the other one lead rounds on all of our patients and get real-time feedback on our teaching styles and those kind of things. It was an invaluable experience that I think really helped shape me in the rest of my year. Dr. Dressler has been important to me throughout the year for lots of different reasons. When I was specifically on clinical service, he really helped me with the idea of what it was like to be a hospitalist, getting patient from point A to point B, and he was always there for me to bounce clinical questions off of which I had many. So establish those mentors. They're people that really want to be able to invest that time into you, someone that has interest in your academic development. Finding those people is a big first step in becoming an attending. For our faculty, being a mentor, both these gentlemen that I mentioned, they were willing to take time out of their day, out of their busy schedule to invest in me. And so as you think about faculty in your division, whoever those are, as they start, remember when you were junior faculty and when you started at your institution, you may not have known a bunch of people, and how much it meant to you to have someone come to you, take that time and invest both in your personal and professional growth. So continue to please try and do that for our faculty here. It's really been invaluable for me, and I think it really helps our institution as a whole. Part of that is being a good mentee. So when you come to these people, when I started, I came to Dr. Hunt with a very specific idea of I want to improve my teaching on the wards. I want to be the best teacher I can be on the medical wards. And Dr. Dressler, he helped me. I wanted to be the best clinician and the best hospital medicine I could be for this year. So as a mentee, you need to have direct things that you're asking them about when you start, so that when you show up, you're not just like, please mentor me and help me be a better person. So have set goals when you start, and then that will make the relationship better along the way. You can't treat what you can't see. So this just takes me back to being at the bedside, and that being kind of what I focused on this year. Here at Emory, we do bedside rounds on all of our patients, and I encourage you, especially as you start out, when you're hearing about patients and you're not really sure what's going on, go back to what you know how to do, which is go to the bedside and see a patient, talk to them, take their exam, etc. So that kind of reorients you and the team on the patient and taking care of the patient. So I would really encourage you as much as you can to spend your time at the bedside as an attending. It's okay to not know. Every day, my interns that I had this year can attest. I've pretty much said I don't know to some question they ask me. They're okay with that. They understand that I'm starting out. They understand that there's a lot of things to know. It built trust on our team, honestly, for me to be able to say that I don't know. They were able to say they don't know about stuff, and we were able to learn together. And I go to them and say, let's look that up together. As a team, let's go down to radiology and answer that question. Let's go to pathology, whatever it is, together. So letting them know that you're not perfect, you're not the almighty attending that knows everything, and that makes them more comfortable with you as well. So teach on every patient every day. We made this an emphasis kind of on all my wards teams, but especially when we were with Dr. Hunt, he really instilled this in me, that no matter the patient, no matter even if this is the patient that you get, there is teaching points to be done on every patient for every day. It says the admitting diagnosis is, we'll need you to take this one for the team. So we would tell our interns, no matter how little teaching you think there is to be done on a patient, there's something you can talk about every day. So being intentional about that, taking 30 seconds, 1 minute, 2 minutes every day, and teaching on something specific on each patient really made our team kind of refocus on this educational mission of our institution. Remember June 2015. So in June 2015, I was in my last month of intern year, and I was on the wards, and I was very tired of having an upper level and an attending tell me what the plan was going to be on the patient every day. I really wanted to make my own calls on the patients, be able to kind of push my ideas. So remember that feeling. Remember back when you were an intern or whenever you were ready to kind of to make your own plans for the patient, and trust your team. Let them be the ones to come up with the plans for the patients. Let them be the ones to guide the patient care. I said that you're Dr. Guardrail. So the interns and the residents are driving the patient car to the destination, which is discharge, and you are just the guardrails along the way, making sure that they kind of stay in the lanes and don't run off the road. So every once in a while, it's okay to let this intern, follow this impulse. This is like the classic intern thing. So it's okay to let your team chase those wild hares every once in a while. It promotes their curiosity, their medical curiosity, and it shows them that you're willing to trust in them and their plans for their patients. And it's all about availability and comfort. Dr. Manning taught me when you get with a team that first day, you sit down and you start talking about non-medical stuff that take 5 minutes. Who are you? Where are you from? What do you do for fun? And just kind of reset and let them know that you're a person, you're there with them. You're not just coming in to be their boss for the rotation and tell them how to manage the patients. As you build that availability and comfort, your trust in your team, the team dynamic overall will continue to improve. The name on the door. So when you're coming attending, you are responsible. Patients are like elephants, I determined. They don't forget. They do not forget your name when you're the attending. As a resident and intern, they never remembered my name ever. But when I was the attending, I was able to walk in every day and the patient was like, "Oh, Dr. Maddox, good to see you." And so that to me was like a kind of a manifestation of how you're the one making the call now. You're the one the patients remember. You're the one that's in charge of the team. So embrace that role. Embrace the new responsibility that you have. You're finally the one that gets to make the calls on the patients, and after your team is kind of giving you that input, you're the one that makes the tough calls. So the difference to me between being a resident and attending, as a resident, it's always nice to have that backup to be like, I really don't know exactly what's going on with this patient, but the attending will be the one that ultimately makes that call. So when you're the one that is making the tough calls about the patients, what they're looking for, what the team is looking for, I think, is for you just to make a decision and be decisive. They're not expecting you to be perfect with every decision you make, and they understand that there are risks and benefits with every decision. But to me, the way you lose trust in a team quickly is to kind of waffle and not be decisive about patient care. So making those tough calls about the patient, to me, was another big thing that I learned as I transitioned from resident to attending. To summarize, you're ready. If you graduate from this program, I promise you are ready. You are all just as and likely smarter than me. You can go do this, I promise you. Remember these 4 things. To find and lean on your mentors as you start. To when in doubt, go back to the bedside and learn from the patient, or refocus yourself on what you're comfortable doing. Trust your team to make the right decisions, and to take ownership of your new role. Thank you.
Hey everybody, I'm Alejandra. I'm the ambulatory chief resident, and my topic today is the primal lessons I learned in residency. As a disclaimer, all the patient pictures presented here are presented with permission, and I have 2 very simple objectives for you guys today. What I really want to do is I want to discuss the top 5 life lessons I learned during residency using this PRIME paradigm, and I'll explain what PRIME is in just a second. And ultimately, I hope that after my talk, I will have encouraged you to develop either your own tool or paradigm to reflect on your own training and or your career journey if you're a veteran in the audience. So what is PRIME? A lot of you guys have heard of PRIME as our mentorship research program that we have here at Emory. Some of you may be mentors. Some of you may actually be the residents in the program. I'll leave that to the experts. I won't talk about that today. I'm not a mathematician, so I won't be talking about prime numbers. And as much as we all love 2-day free shipping, I won't be talking about Amazon Prime today. But really think about this. Every day when you come into work, you're presented with either a difficult patient encounter, having to deliver difficult news, or even a diagnostic dilemma. And often, most of the times when we think about it, we think about these as problems. But my argument is that if we take some time to reflect and really focus on what's meaningful about it, we can actually turn those problems into opportunities. So reflective writing is actually something that has been really popular over the last 10 years in medical education, and it has shown increases in satisfaction and also empathy, but also something that really tends to kind of stop in medical school, something that we don't really focus on in residency or even as we progress in our careers. So really for the next 5 minutes, what I want to do is kind of give an ode to the art of medicine and those people who taught me, and ultimately talk about these 5 different tenets that I learned from these different people: patience, resilience, independence, mentorship, and evolution. It's my prime. So I'll start with patience. So picture this. I was a PGY1 on Emory wards, and the very first patient I had to go see was Mr. RS. He was admitted for the evaluation of positive blood cultures, and yes, eventually he was diagnosed with subacute endocarditis, and yes, I learned a ton about it. But really the thing that I remember most about him was this. I walked into the room and I told him, we're going to have to order an echo. And the very first thing he asked me was, well, how much are you going to be getting paid for that? And I was just taken aback. And really over the course of the next 10 days as he was in our team, he always would accuse us of wanting to profit from his illness. And I remember reflecting on that experience and thinking, wow, he really has a lack of trust in the medical field, probably because of things that had happened to him. But ultimately, he really tested my love for medicine. And I reflected sitting there thinking, I would sit with him 20 to 30 minutes explaining every test. And ultimately, he really made me focus on the fact that I really needed to work on my patience. And while he wasn't the first and only patient that tested my patience, he was really one of the most memorable. And what I really learned about patients like this over the course of my training and over the course of my career was that, hey, not all patients are going to trust or like me, and I won't always know the answer, and it's really going to take a lot of patience to transition through changes, through training, and also to transition from being a resident to an attending. Which brings me to my next point of resilience. So this is Mr. JM. He was a 55-year-old gentleman. He was admitted. He was one of my patients with advanced alcoholic cirrhosis, and I met him as a PGY2 on Grady wards for his 5th admission in 2 months for variceal bleed and decompensated cirrhosis. And as I sat there reflecting with my team, I said, I don't know that he has such great quality of life. And I made a lot of assumptions about his care and about how he felt. And the problems that I saw was, well, he has multiple readmissions for various social reasons. He's not a transplant candidate. And he just kept getting readmitted with really no end in sight. But boy, did he prove me wrong when for the next 8 months, thinking I thought maybe he wouldn't make it through more than 1 or 2 admissions. For the next 8 months, I would get notifications on Epic that he was admitted. I would go in and visit him, and every time he would greet me with a smile like this. And really what I learned from patients like this, especially our dear patients at Grady, is that our patients that live with chronic incurable illnesses can actually teach us so much about resilience and about stress, and that when we underestimate how much they want to be involved in their care, we actually kind of impede the resilience building. Which brings me to my next patient. This is Mr. JR. I met him when he was 40. He's 44 now. And he was one of the very first patients I admitted on Grady wards. And he was admitted for advanced diabetic nephropathy and retinopathy. And he eventually became one of my first primary care patients. And it became very apparent early on that he would need HD in the near future. He was losing his vision, and as a result, he couldn't drive and he couldn't provide for his family. And as a result of that, went into a very severe depression. And over the course of the next 24 months, we worked together, and while his circumstances didn't change, he did have to start hemodialysis, he was able to find some newfound independence even with the confines of his circumstances. And really, when I had patients like that, and him specifically, I just spoke to him on Sunday to tell him I was leaving Atlanta, and we both really just focused on what was most important to him. And what was most important to him is that I just heard him, and that I listened to his wishes, and that in doing so, I dignified his circumstances. And really, that's the questions I will continue to ask myself when I think about this patient, is how can I value a patient's independence and desire to be heard as part of my daily practice? That brings me to mentorship. No career journey is ever complete without a great mentor, as Spencer has told us. And you all know her well. This is Dr. Higgins. She's the primary care track program director, and she was one of the very first people I met at Emory, even during my interview. And she also became my first mentor at Emory. And while we focused a lot on my career development and my research and what I wanted to do and who I wanted to be when I grew up, she also, would focus on the positive things that I could do, but also would really push me to do things I didn't want to do. And I remember one time talking to her about, reflective medicine and thinking about all of the things that, we've been through. And she said, you really should do this thing called the 3 good things, which is you take a period of time, and during that time you kind of consider what are 3 good things that happened today. And she made me do that for 30 days and report back to her. And boy, did I tell you, I did not want to do that because I was like in residency and there was nothing good about it. That's how I felt anyway. And so what I learned from her is that, a really good mentor will actually expose your strengths, but also will really challenge and make you work on your weaknesses. And that's a mentor that I really, really hope to be like in the future. And again, we're all going to change. This is us as interns, and this is us as our graduating class. And when we started, we certainly had a style of delivering patient care, but it certainly changed. And my co-chiefs, when we started last year, we certainly are different people than we are today. And so what I've learned over the process of just working with all of you incredible colleagues is that we're all going to change. Evidence is going to change, so our practice of medicine has to change. But also our patients are all going to be different. So we are definitely going to have different styles of providing that care. So I leave you with these final reflections. I came up with PRIME. When I thought about my journey, that's what I came up with. But have you taken time to really reflect on your career journey, on your training, and think about who has been influential over the course of your career, or what circumstances or patient encounters have really taught you about that art of medicine? And what are your valuable lessons? And for you mentors or mentees in the audience, how can your mentorship style be different to cater to different mentees? Thank you.
$12:55. Look at us. 6 lectures in 1 hour. We have approximately 5 minutes. Is that a little too ambitious? Okay, I asked the outgoing Emory Chief Resident. So if there are any questions, before we go to questions, please, I just ask that everybody at every site, please give a round of applause for the one full amazing year of dedication, but also this great teaching today from our outstanding Chief Residents. This has definitely underscored that there's always time to teach, and was an exciting way to shift gears and let us learn lots of different things and give us plenty to reflect upon. What questions or reflections? Oh, look, Dr. Dressler's already up.
I was going to serve as the
roving
chief, but
okay.
I'll also ask a question. That was amazing from each and all of you guys, and I think we all learned a lot and appreciate the reflections and the teaching from each of you both today and throughout the year. The one question I'll have will go to Tyler, really around, are there specific interventions that we should do as teams to systematically reduce our distractions to improve our care?
Yeah, I appreciate that question because I think I highlighted one specific distraction in cell phone use, but there are plenty of distractions that we all see on rounds on a daily basis. I think one thing we can look to our nursing colleagues, and one example that they use is whenever they are pulling meds from the Pyxis, many times they actually have zones where you are not to interrupt that nurse from performing that task. And I think in medicine, in our field, we need to build in kind of safe zones where we eliminate some distractions. Now, some of our distractions have real clinical relevance. For example, if you get a page from a nurse about a critical lab or something that needs to be taken care of, I think that's important. But I think that we as providers, set up zones for ourselves where we say, everybody, put their cell phone on silent or on vibrate. Let's minimize interruptions during rounds and institute changes like that.
Other questions, comments? Well, hearing none, our chief residents are done. Thank you for your attention, and congratulations to all of you residents who voted for yourselves for Beast Mode as Best Conference. Our favorite thing about that winning the award for Best Conference is that it is the award that you give to yourselves, because it is the conference that you teach to yourselves. So thank you again, and thanks for your attention, and thank you for a great session.